next 20-30 minutes about assessment in the emergency department. Okay, so why do people attend accident and emergency? So pain is one of the most common reasons patients seek medical attention. So I cannot stress enough that if we deal with that pain quickly, then their experience of A&E is going to be 10 times more efficient and more calm and more polite and less stressful than anything I can tell you throughout this whole lecture. So we just need to deal with pain properly, and we need to review. Once we've dealt with that pain, we need to make sure that they're still pain free. Okay. And when the medical practitioner or the nurse or the doctor sees them, it makes our job 10 times easier. So if I can examine an abdomen without them screaming out in pain, then literally it's so much easier to diagnose someone. Okay, so anxiety, nausea, vomiting, confusion, needle stick injuries, hemorrhage, fever, mental health conditions, rashes, and social problems. Loads of different reasons people attending. So we have a very basic assessment in accident emergency. We used to use quite a lot, which it works quite well in a very basic way. So what's your subjective assessment? So that is what the patient is telling you. So I've come in with chest pain. It feels sharp in nature. It's 10 out of 10 in severity. It's making me feel nauseated, sweaty, this sort of thing. So what's your objective component? So your pain score can be objective because you can score it out of 10 or 3. What can you see? So you can see an open wound to the chest. It's 5 centimeters. It's deep. They're breathing very fast. They look pale and sweaty. So this is your objective part. Your assessment is your examination. So do they have unilateral chest wall movements? Are they short of breath? What is their respiratory rate? What is their oxygen saturations? What is their pulse rate? What is their blood pressure? Are they peripherally cyanosed or very mottled peripherally, to say they're shut down? This sort of thing. So what is your plan going to be? So my plan would be to provide pain relief, possibly to get a chest x-ray done as soon as possible to make sure they haven't got any pneumothorax. And you can do all of these things. Even if you can't request a chest x-ray, you can speak to a clinician and say, I'm concerned about this patient. They've got pleuritic sounding chest pain. They need a chest x-ray because I think they possibly have a pneumothorax. Okay, and then evaluate. So you've given them pain relief. How's that worked? You've done the chest x-ray. Get someone to look at it to make sure they don't need to go into resus for a chest drain. So it's just thinking, it's making sure you review everything you're doing as well. Okay. This is what I still use. This is really good. So you've got your Socrates model. So it's site. So your chest pain, whereabouts is it? It's the left side. Onset, when did it start? Well, when I got stabbed. So it was about 2 o'clock in the morning. Character, what sort of character is it? Or it's sharp in nature. It hurts when I take a deep breath. Does it radiate anywhere? Well, yeah, it goes through into my back. As I say, when I take a deep breath, it's like really painful in my back. Are there any associated symptoms? Yeah, he was sweaty, he was nauseated, timing. And that's more, so did it happen at a particular time of day? If it's been going on for some time, that sort of thing. Exacerbative factors. So it's much worse when I take a deep breath in. I can't take a deep breath in. Okay, so that's an exacerbative factor. And severity. So what's your pain score? Okay, so that's quite a good one. I like. I think this one's used more by paramedics, but it's exactly the same really. So onset, location, to where is the pain, how long has it been going on, what does it feel like, are there any aggravating or alleviating factors, does it radiate anywhere else, is there a pattern? So does it always happen at night, does it always happen in the morning, first thing when you wake up, and how painful is it? So Health promotion. This is quite an important thing, especially as nurses. We should be doing this in accordance with our code of conduct. So the Making Every Count initiative, Forum 2012, suggests we should not simply treat people when they're ill, but try and stop them from getting ill in the first place. So any sort of health promotion, if we can speak to them, talk about their alcohol intake, talk about their cigarette use, talk about exercise, weight loss, all of these things we should be doing. I grant you that probably in triage, when someone's in pain, is probably the worst time to do it. So don't. It's about doing things appropriately as well and taking small steps. So maybe when the pain is relieved, you need to talk to them about their alcohol use, or maybe like staying in groups when they're going out, so they're not on their own, so they're more protected. This sort of thing. So evidence-based handovers. Hopefully everyone will know exactly to do an SBAR, because SBARs are really straightforward. So what is an SBAR? So an SBAR is a very easy to remember mechanism you can use to frame communications. So you can use it in handovers, you can use it in your communications on the by email, you can use it for all sorts of different things. Okay. So what does it stand for? So S, situation. So what's happened? Okay, so I've got chest pain. Yeah. Background. So I was stabbed in the chest at 2 a.m. He's got pleuritic, sounding chest pain. He's taking much worse when he's taking a deep breath in. Assessment. His pain score is 10 out of 10. He looks pale, clammy, and he's got unilateral chest movement. Recommendation. So what did I recommend? I recommended a chest x-ray. I recommended pain relief, and urgent escalation to one of the ED clinicians. So, and then obviously you're going to review that as well, make sure that the plan has been followed. Okay, so we know that doing this SBAR well, according to NHS England, increases patient safety. So how can it help you? So inadequate verbal and written communication is recognised as the most common cause of serious errors. So if you make a medication error, if you make a diagnostic error, we know that this is one of the most common causes because of communication. Okay, often complaints are the most commonly caused by lack of communication as well. Okay. So SBAR is an effective way of leveling the traditional hierarchy between doctors and other caregivers, building a common ground. Okay, so we're all talking the same language. Yeah. So if I do an SBAR to you, then hopefully that's given you enough information to get to start your management plan. Okay, and treat the patient appropriately. So recommended uses and settings for SBAR, like I said, you can use it for everything. So urgent and non-urgent communications, verbal or written exchanges, emails, escalations and handovers. So if you're phoning a doctor, so sorry, I'll go back. In 10 minutes time, you phone a doctor and you say, I'm really concerned about this patient. He looks terrible. Okay, so let's go back to your SBAR situation. What's the patient's name? What's the hospital number? And what did they come in with? Yeah, background. So they were stabbed. Okay. Assessment. Their breathing is worsening. They become more clammy. They become hypotensive. And recommendation: I need you to come see the patient urgently because I think they're peri-arrest. Okay, so this is a really effective way of communicating. Not just, I'm really worried about this patient, please come and see them as soon as you can, because it doesn't tell the doctor anything or the clinician anything. Okay, so this is why SBAR is a really good form of communication, making sure your action plan is followed. Okay. So yeah, well, I've done a little example here. So identify yourself. So this is your situation. So my name is Robert Bradley. I'm calling from A&E. I've got Joe Bloggs. He's come in because he's got chest pain. So then you go to background. So he was stabbed at 2 a.m. the left side of the chest. Now he can't take a deep breath without having pain. Okay. Any significant past medical, and they've got no significant past medical history. Assessment. So his respiratory rate is now 32. He's pale, clammy, looks terrible. Pain is 10 out of 10. I think he's going peri-arrest. Okay. So recommendation: I want you to be down in the next 5 minutes. Otherwise, I'm going to put a crash call out. In fact, I might just do that anyway. Thank you. Goodbye. And that's it. Okay. So this is just another example of an. I hope that was interesting. I kept it short and sweet. Any sort of more information I can give you, please come and find me on A&E, and definitely start using your Socrates model, because I think it helps you gain a much more objective picture as to why the patient has come into A&E. Helps you to differentiate between pleuritic and cardiac sounding chest pain. Helps you to form that diagnosis picture in your head. Okay, thank you very much.